So the other day, I posted on LinkedIn 2 posts about antipsychotics. One was comparing mortality caused by antipsychotics in children. Mortality caused by adding an antipsychotic to a medication regimen in children versus mortality by neglect and abuse. And the difference is impressive. It's like mortality by neglect and abuse is like 2.5 kids are killed for every 100,000 kids. And mortality added by antipsychotics is on the order of 45 per 100,000. So it's like almost 20 times the mortality caused by neglect and abuse. And the reason I put them together is quite obvious, is because we are a profession that treats behavioral problems with antipsychotics. Behavioral problems, kids with behavioral problems, we treat them with antipsychotics while we oppose spanking. Spanking and abuse are not the same thing, but if someone were to claim they were, there was these numbers, right? Those numbers. And the other post was mortality added, let's say excess mortality by antipsychotics, when they are added to a medication regimen, to an antidepressant, to treat people with major depressive disorder without psychotic features, compared to mortality by suicide in the same population. And again, antipsychotics kill about 2 times more people with major depressive disorder than suicide. And that's the available data, right? A few weeks earlier, I presented the same piece of information to a group of colleagues as a virtue of my profession, of my position as a director. And the reaction was the same. People got mad at me. And it's always like that. Why would I do that? Why would I do something that makes people feel mad at me? What kind of motivations could I possibly have? There's another one. So I had very recently a discussion on the syndromic nature of our diagnosis, meaning it may even look like a disease. There's some hints that it is a disease, but we haven't found the disease yet. So until proven otherwise, we're talking about syndromes. People get mad at me. Why would I do that? Why would I care enough to do so, to present this information? Is it because I don't care about psychiatry? Because I believe psychiatry should end? Or the very opposite? So you see, psychiatry is one of those things that allows to us a huge degree of self-deception. If you get a group of 10 shrinks and you ask them which one is the best here, likelihood is you're going to get 10 different answers. And the reason for that is because we have 10 different criteria, and probably we have 40,000 different criteria for the psychiatrists and so many thousand for the nurse practitioners. As such, as it should, it's an art, I get it, we have no identity. We can believe whatever we want. We don't have proper criteria for how psychiatry should be practiced. And as a matter of fact, all my discussions go like that. I present some questions or thoughts, usually questions, say, hey, how about this? Like, why do we continue the carousel of antipsychotics when the patient's not responding, despite visibly having a lot of side effects? Why do we continue, even, after Clozaril has failed, why we never consider just reducing the dose? Why is that never just a question? I don't know the answer. Or I present data, just like the one I mentioned in the beginning of this chat, and people get amazingly emotional about it. I assure you, my goal is not to upset anyone. Suicide is another example. We have no data proving that whatever we do makes a dent on suicidality. If anything, the opposite. If anything, we have more data to suggest that we're completely at odds with this thing. We don't freaking know what happens. Why would I point that out? Why would I want to make our limitations in that regard so clear? Now, you may be thinking, well, but I know I make a dent in suicidality. I can. And here's the challenge. If you ask 100 psychiatrists, they all will say, if you ask maybe 40,000 psychiatrists, as we have in the United States, it's possible that about 39,000 will believe they are making a dent in suicidality. If that was true, data should reflect it, but it doesn't. Another thing that I see frequently is maybe some colleagues believe they have remission rates that are higher than the ones of their peers. So when I point out our low remission rates, you name it for what, they get mad at me, and I wonder if they're getting mad at me because they are perceiving that as a personal attack, as if I was attacking you when I say your remission rates are as bad as everybody else's. But I'm not. I'm not attacking you. And I'm not attacking psychiatry because I love psychiatry. What I'm doing is I am just trying to figure what the truth is. I'm trying to figure what are our limits and the extension of our capabilities for various reasons. One of them is that we hurt people. So, for example, when I say antipsychotics could be a factor hampering recovery, which we have data to support, or, okay, if we don't have data to support, we have at least data to ask the question, right? And if we don't have data, and we do, we could have the logic of all the side effects of these medications, cognitive side effects, and say, is it too far-fetched to imagine it could be hampering recovery? But when I point that out, I'm not pointing that out to upset you. I'm pointing that out to say, hey, can you help me look into this thing? Because it's very difficult and it's very anxiety-provoking for myself. When I point out those things, I'm not saying everything you do is wrong. I'm actually saying, why don't we keep in mind this thing? Why don't we keep in mind this possibility? And if we were to take this possibility into account, how would I manage a patient that meets criteria for schizophrenia? We cannot possibly believe that our therapies, with the results we have, are exclusively beneficial. It just cannot be. Our remission rates and our response rates are very, very low. And the medications cause damage that surpass, some of the medications cause damage, at least some of them, that surpass the damage that we're trying to prevent, suicidality. So our results are too bad to outweigh the negative impact, which suggests maybe we make just a small difference, but we may be causing also a huge damage. When I say that, I'm not attacking you. I'm not pointing your shortcomings. I'm pointing my shortcomings as well. We're all crappy. This is psychiatry. And I have seen people stomp their chests and say, oh, my patients get better. And again, this is a virtue of my profession. I have access to the standard measures of remission that pretty much every clinic uses. And I get to see, hey, it's easy to crush. This is not true. We are all having very mediocre results. Look at our data on remission rates for major depressive disorder, for generalized anxiety disorder, our data on remission for schizophrenia. Maybe the remission or the prevention of manic episodes by chronic use of mood stabilizers. And I'm talking about the mainstream data. I'm not talking about a critical data, antipsychiatry data. I'm just saying, mainstream, the same textbooks that you and I used to get trained on. Why would I take the time to tell you that? Why would I be doing that? It's not to upset you. My brother, I do not do this to upset you. If anything, I do this because I love psychiatry and I love you. And I know you are a very good and well-intended person with a good heart. And I love psychiatry for the same reason, because of the good it can do. But there's really no question that we are biased to remember more of our successes, to keep tab of our successes. And they're there. You know, we have unequivocal successes, no doubt about it. I have seen cases, we all have seen responses to medications that were like, oh my God, and like really that treatment clearly touched that person's life for much better. We all have seen that. Is it too far-fetched to imagine that because you tried one medication to one patient that had this wonderful result, you're going to be more inclined to try that to everyone? But that never happens here, because these successes are very, very few. But we keep a close tab on them. They have a huge impact on us. But I don't think they justify the generalization of our treatments to everybody. Of course, there's some people that will respond to antipsychotics and do great, and people that cannot live without it. By logic, it cannot be true for everyone. The same for antidepressants. This is a profession in which we fight for inches. And even those inches are questionable. You know, for example, for schizophrenia, staying out of the hospital first to 12 months, that's most studies will assess that. Staying out of the hospital and the reduction of perceptual disturbances. But now we have data to say, oh, in the long term, maybe not so good. How about antidepressants? We are trying to improve mood without changing the reality in which this person lives. That's a very questionable inch for which we're fighting for. Do those inches justify the damage we cause with medications? You know, and you're a well-trained doctor, you know the side effects. But then you may say, well, but it's not that the treatments are bad, it's that the task is very difficult. It is true, it is very difficult. It's even maybe impossible, you know, like, again, trying to improve mood without changing reality, being mood responsive to reality. We're you know, what kind of goal is that? But yeah, it is very difficult. However, we have to also consider that our practices and paradigms are tested and sold by the same people that profit from it. Am I not to question? Are we not to question these things? Take for example, Stahl's Psychopharm, right? Dr. Stahl, he's the top earning psychiatrist when it comes to money from Pharma. Something last time I checked from a paper from Gotchi, he was on $8 million from pharmaceutical companies. He writes a Psychopharm book. Am I to trust that source? Can we at least question it? Now you may say, well, Rod, you're biased on your view. You're right. I am biased. I'm biased towards psychiatry. For all that psychiatry could be, if you take your time to read the arguments of the serious people in the anti-psychiatry movement, because you're right, if you say that some things are too much, I'll give it to you. But if you read the argument of some of the serious people in the anti-psychiatry movement, some of them are pretty solid. And they're talking about our art, the thing that you and I chose to be what? Can we say it's the core of who we are and what we do during our existence? A career? It's a fair statement, right? They're pointing out limitations of our art. Why is it so hard for us to entertain it, considering how much we love it? So when I started this whole thing, the podcasting, these questions and things like that, I was hoping if we could actually entertain these questions and establish the true extension of our capabilities. And if you're thinking, just in case you're thinking the damage is not that bad, the Pentagon just released a report saying that 80%, approximately 80% of the American youth is not fit for military service. Now, I don't care about the military. I care about the fit in the service part of it. And the reasons are psychiatric diagnosis, and I know that we have been overdiagnosing. You may say, well, we miss a lot of true diagnosis, like people that will meet criteria for bipolar don't get the diagnosis. Fair. But in general, the diagnosis was expanded, right? By far, 1 out of 10 Americans are carrying a diagnosis of bipolar right now. We are diagnosing human condition. We are diagnosing being a person. We are overdiagnosing just being a human. And in addition to those diagnoses, there is, of course, the conditioning. And we know that a lot of the medications we prescribe do cause deconditioning. Obesity, heart problems, metabolism changes. By the way, there's a huge pushback coming. Yeah, you can call me a prophet if you want. There's a huge pushback coming for the way we practice psychiatry. And just ask you, please remember me when you see it. But if you're still questioning my words, think of the patients you see in your practice, the people you inherit from other providers. We have long ago crossed a threshold of absurdity when it comes to polypharmacy and when it comes to multiple diagnoses. And all I'm doing is inviting you to explore these things with me. That is my motivation. I never did this to upset you. I only wanted to invite you to take this journey with me. When I posted that data about deaths related to antipsychotics in major depressive disorder without psychosis versus death by suicide, a colleague, very nice guy, he answered, do you see psychotic patients at all? Like, honest question, do you see psychotic patients at all? Visibly upset. What was that reaction about? I wasn't even talking about psychotic patients. I was talking about MDD and just saying, hey, this medication is dangerous. Why was he so upset? Why did he feel attacked? Why presenting information, presenting facts, or even as much questioning this thing? Why would that make people feel attacked? What's going on? I really apologized. I really apologize because I rather be loved by far. But consider this. Think of any of your patients. Any of your patients. Someone gets to any one of the patients you have seen with all the passion and dedication you have for this art of psychiatry. Imagine that someone gets to this one patient and says, listen, there was this medication we thought it was great, but now it seems to have a lot of side effects and seems to hurt people a lot. And to be honest with you, the benefits versus the risk, it's more of a gray area. It's not very clear. And then they ask your patient after telling them that, do you think your doctor would want to know that? What do you think your patient's going to say? Now, consider that our reputation has been going south quickly, right? The reputation of our profession has been declining quickly, very badly. Still, I bet your patients, because they saw your respect for the art, would say what? My doctor would like to know that because he cares. My doctor cares about what is the truth. Do we? As a profession, do we? So I guess I'm apologizing for the emotional reactions I cause. And I am apologizing for not making my goals clear when I present these questions. The truth is that many of our practices don't allow us to be sure when it comes to its efficacy and safety. We have too many questions that were not answered. And the safety of a lot of things we do have not been established. I wouldn't say the safety, but the safety compared to what we're trying to do, what we call precautionary principle, You cannot have a therapy that is worse than the problem. Look what happened to benzodiazepines, for example. After 50 years prescribing this thing, we found out it actually hampers improvement of PTSD and phobias. It actually makes them worse with time. Take a look at failed randomized controlled trials for antidepressants. Can we really be sure that they actually work for what they claim to work? Can at least we question what they're doing when someone reports improvement? What is this improvement thing? What is this phenomena? Some have claimed that antidepressants can curb the results of CBT in the long term, just like benzos do. Yeah, and you may say, well, but it's all open. It's not settled. And I'll say, yes, you're right. But it used to be in medicine that until something is settled, we're more cautious when we use it, because we do no harm. Now we have 3 randomized controlled trials running to answer the question if when you have remission of psychotic symptoms in schizophrenia, should we taper the antipsychotic or should we continue the antipsychotic? Why there are these 3 randomized controlled trials running? Because we don't know the answer. We do not know the answer. Yet, we continue to treat the problem as if we should continue the medication forever. How about when it doesn't work? People that go through this round and this medication and that combination and different antipsychotics and clozapine plus this, clozapine plus that. Do we have data saying, hey, we have tried to stop the medications in these people and the results were the same, except they don't have high cholesterol anymore? We don't know that. We don't have data for that. We only have, for the most part, data on the short term. Look what they found about opioids. It was proven to be decent in the short term for acute pain. They draw the conclusion that it could be used chronically. Look to America right now. Is it too far-fetched to imagine that we're doing the same with our meds? I am only inviting the inquiry. If questions like this generate so much resistance, maybe we could ask ourselves why. Am I challenging a religion of sorts? Unfortunately, our results do not justify our stagnation when it comes to practices, concepts, and paradigms. We're not doing a job that is so good that it's okay to continue the way it is. No, we don't. Again, look to our remission rates, our response rates. They're all very small, very modest. They're modest enough that it will be fair to question these things. Are we in position to refute the Bates theory of schizophrenia? The way cognition works kind of thing. And you're going to say, well, Rod, but that's not even testable. I agree. It's not testable. For the most part, those theories are not testable. Or Freud, 100 years ago, 120 something, he said, the mania happens when you successfully suppress unconscious content that is trying to come to consciousness and would generate anxiety. When you successfully suppress that, the relief is the mania. You can't test that. But you know what we can test? We can test our disease hypothesis. And we have been testing for $20 billion now. And we haven't found. So hence my point. Can we refute the other hypothesis? Because the one that is testable so far didn't produce enough. How about chronic use of medications to prevent mania? We have, with the best medication, that is lithium, we have like 70% recurrence of manic episodes within 2 years. And that's with the best medication. So when you're prescribing to a patient, all the side effects, those medications are not candy. Our medications are tough ones. Are we sure we are postponing a manic episode? Can we be sure of that? How many times we have seen people have manic episodes and then manic episodes, and how many times can we claim, okay, we have enough information to claim we're making a dent, we're breaking a pattern? If someone has a manic episode every 3 or 5 years, is it justifiable to take medication every 3 or 5 years? I mean, like chronically, or we should be focusing on the crisis, on the acute episodes? I don't know. But I'm inviting the question because it seems that we don't have data enough to justify the way we do. At least we don't have data enough to justify the way we offer these treatments for 100% of each people that meet a given diagnosis. There's an estimate that 40% of psychotic exacerbations are a result of antipsychotic hypersensitivity psychosis. And if you haven't heard that yet, just Google it or listen to my interview with, it's on Spotify, with Dr. Adderhold. I also made one other interview later to question those things. I don't remember the name. Maybe a psychiatrist we know is dying. I don't remember. But if you don't know, just Google antipsychotic hypersensitivity psychosis, which is pretty much the same as saying antipsychotics are worsening or causing a psychotic episode. 40%, it's an estimate, okay? Let's say we don't have the precise number. 40%. So should we be offering tapers of antipsychotics for people that are in remission or not? Or should we offer tapers for people that have residual symptoms or not? What's the point of continuing harmful treatments if you don't have measurable results? And frequently we don't have measurable results. We prescribe a medication, patient comes and he's, maybe I'm better, maybe I'm not better. Yeah, maybe you're better, maybe you're not better. It looks like you're a little bit better. Is that justifiable? I am just asking the question, okay? Some people have questioned, some colleagues of ours have questioned the criteria for success of treatment in trials of antipsychotics, meaning suppressing perceptual disturbances and keeping out of the hospital in the first 12 months may not be a goal or a result that justifies the chronic use of it. It's just a question. We really don't know what happens after 15, 20, other than tardive dyskinesia and cognitive impairment. We don't know if the benefit is still outweighing the risks. You know who takes those questions very seriously? Pharmaceutical companies. They do take it very seriously. They have already financed publications saying that injections reduce the risk of antipsychotic hypersensitivity psychosis, I should say. And they also have financed expert panels to review the long-term consequences of antipsychotic use, and they concluded, of course, that it's good for you. But then again, we have, in our profession, for some reason, we are geared towards interventions. Of course, we're trying to do something for our patients. I spoke about it in the past, what I call oral tradition in psychiatry. If you take a group of 5 shrinks for lunch and one of them during the time they're eating says, well, and Seroquel is very useful for PTSD. Nobody questions anything. Likelihood is in the afternoon, the other 4 will be very inclined to start prescribing Seroquel for their patients that meet criteria for PTSD. But if the next day we go for lunch and I say, well, Seroquel failed to prove failed to prove itself for PTSD. Well, that, once the practice is established, that leads to the highest degree of scrutiny and questioning. They want to see based on what I'm saying that. Matter of fact, I don't have to provide any proof that something doesn't work. I'm just saying it doesn't work. You have to provide proof that it actually does work, right? But we have this bias towards the interventions. If we were to work based on that premise, we could start prescribing omeprazole for schizophrenia as well, because nobody proved it didn't work. And now you may say, well, Rod, this is not looking like an apology. So check this out. I'm apologizing for my lack of skills to engage you. I'm apologizing for failing to show you my true intention with those questions. And my true intention with those questions is to save this profession that I love so much and that I have seen do so much good for people, but also I have seen do so much damage. Okay? The reason I share these questions is because I need help to think them through. I need help. Brother, I know you. Okay? Picture this. You are in your psychiatric unit working. You cannot tell me with a straight face that we haven't reached an absurdity level with our practices. When you see a medication regimen and the number of diagnoses that a patient has received, you cannot make a claim with a straight face that our profession is in clear decline. We are declining. The profession is losing quality, is losing brains. And it's not, we can blame other people, but it's not other people's fault. It's the fault of our paradigm of thought. Because if we have the majority of us doing that, either we're going to blame one by one. Is that what we're going to do? We can't. These questions eat me inside. I feel very anxious. And this is why I'm apologizing. Maybe I have been projecting my anxiety in these questions to you. But that's not my goal. My goal is, the reason I'm apologizing then is to say, please forgive me. Consider that I may inadvertently projected my anxiety on you, but I need your help. It's going to take nothing less than all of us to fix our field. And it does need fixing. And I know that you know that. I have to start somewhere. I apologize for failing to entice you to ask those questions, despite the fact that you gave me your ears. Thank you for listening again.